If we can go, Joe, please. Okay, thank you everybody and welcome to the first meeting in public of the Joint Committee since January 2020. Yes, it seems like a very long time ago, so welcome to you all. I hope you're all fit and well, and I'm delighted that we're meeting in public again, albeit in a very different way. Since we last met, the health and care partners in our system have been dealing with the impact of COVID, as we all know. Staff in our organisations have played a huge part in responding to the pandemic, and I would like to pay tribute to them all for their hard work and commitment. COVID-19 has also meant that we've had to refocus and reprioritise our work as a partnership. Later on the agenda, we will be considering the partnership's response. This includes the work we are doing to better understand and respond to the pandemic and our approach to stabilise and reset the role of this joint committee. Our shared vision, mission and staying remains the same, and our services support that we meet the current and future needs of the people of West Yorkshire and Harrogate. In such challenging times, collaborative work is obviously very important and more important than ever. Alongside the impact of COVID, the commissioning landscape in West Yorkshire and Harrogate has changed. This has meant also changes in the membership of this particular committee. The Bradford and Craven CCGs have merged to form a single CCG. Harrogate CCG has merged to form North Yorkshire CCG, which is now an associate member of this committee. Also, since we last met in public, Dr. Khalid Naheem has been appointed Chair of North Kirkley CCG, and Dr. Jason Brock, Chair of Leeds CCG, and Dr. Charles Parker, Chair of North Yorkshire CCG. And I'd like to welcome you all here today for this joint committee. I'd therefore also like to propose a vote of thanks to the members who've left the committee. They were Andy Withers, Gordon Sinclair, David Kelly, Sahal Abbas. This will also be the last meeting in public for Richard Wilkinson, our lay member, and on behalf of myself and the whole committee, Richard, thank you very much indeed. Moving on after the welcomes, and everybody's great, so that's nice to see. I'd like to first receive the apologies. We've received apologies from Helen Hurst, and who's going to be deputised today by Michelle Turner, the Strategic Director of Quality in Nursing. We've also received apologies from Amanda Blur and Charles Parker from North Yorkshire, albeit they are now, as we know, associate members of this committee, those two particular posts. Additional attendees today because of one of the papers, but as always, Katherine Thompson is most welcome. So welcome, Katherine, to this meeting today in public. She's the Programme Director for our Planned Care Programme. Moving on, if I may then, very swiftly, on the domestic arrangement side, please. Clearly there's no toilets apart from in your own home today, so that's unusual. I normally talk about that and the fire escape. So if you dash off, I clearly realise in your home setting you've got a problem, so no problem with that. But given the COVID-19 restrictions, obviously we're holding this meeting via Microsoft Teams. This may change the dynamics compared to previous meetings, but we have had practice in using this technology, all of us, for some time now, and I'm confident that as valuable members it'll be a productive meeting as we normally do. It would be helpful, however, if you could continue to do the following. Mute your microphones where you're not presenting or speaking. Put your camera on when you're presenting or speaking, or leave it on or off during the meeting. It's up to you, depending on whether you get a good response or not for your Wi-Fi system. But please use the raise hand function to let me know if you want to contribute or make a contribution or make a comment on that. If they're the rules, then please, if I just might remind you of the role of the Joint Committee, please. This committee is made up of 6 West Yorkshire CCGs. North Yorkshire CCG is an associate member. It has delegated powers from West Yorkshire CCGs to make decisions on specific work programmes. Although this committee supports a health and care partnership, it only includes CCGs and does not represent all partners. It is not the business of this committee to deal with issues in the 6 places which make up our partnership. And I think that's the rules all over, guys. But on behalf of myself, it's great to see you all, and I look forward to now moving into our committee in public. As you know, in terms of questions and deputisation, moving on to the next agenda item, the Joint Committee is committed to transparency and accountability. We always seek members and basically the public's view on this. So although we are meeting virtually, we want to give people an opportunity to ask any questions about any items on the agenda. We'll deal with the public questions slightly differently today, obviously because of Teams. Members of the public were invited to telephone or email their questions to the partnership team by 5 p.m. yesterday, so that a member of our team could read them out on their behalf. We have received one question from Jenny Shepherd, which in a moment I'll ask Stephen Gregg to read out for us. So the question, Stephen, from Jenny, please, and then anybody who'd like to respond, fine. Otherwise, as you know, we will send a formal written response to Jenny. So Stephen, please.
Okay, yeah, thank you, Chair. The question is, what, in the view of the Joint Committee of CCGs, have been the effect on the partnership's ability to respond to the COVID-19 pandemic of 1, decade-long cuts to NHS funding, hospital beds and clinical staff, including ICU beds and staff; 2, the government's failure to promptly authorise and direct widespread testing and tracing from the start of the pandemic; and 3, the government's failure to source and provide adequate PPE. Those main questions are followed by a number of more detailed questions in a number of areas, which are largely matters for the wider partnership than the Joint Committee of CCGs. We're therefore not proposing to respond in detail to the questions during the meeting, but as usual, we'll coordinate a response from all the partners covered by the questions. We'll provide a full response in writing, which we'll also post on the website. So that's the intended approach, unless anyone else would like to make any comments on those questions.
Okay, thank you, Stephen. Any comments? So are we all happy that we respond in that way, please? Yep, I will take that as a yes, and Stephen, yes, please, if you could respond in that way, that would be most helpful. Okay, thank you. That is the questions that have been presented to the committee today. I'm going to move on now to the next agenda item, which is the declarations of interest. Are there any members today have anything you wish to declare that's on the agenda that will give you confrontation that you haven't already declared? No? Okay, I will assume then the declaration of interests are all clear. Thank you very much on that. Moving on then, if I may, to the notes of the meeting held on the 14th of January, and I accept that your memory might not be brilliant, but they're there. I'm inviting members to both approve the minutes or take any corrections as you see fit. So we'll go for corrections first. Yes, I've got some. James, would you like to come in, please?
Thanks, Chair. Sorry, I hate doing this, but on item 7220 about the cataracts, there's just a typo there, but it alters it. James Thomas has presented a single. It's presented. That's
Sorry,
all.
James.
Thank you very much.
Yes, you're right. Yeah. Okay.
Yeah, well,
apologies for that.
Change that one.
Yeah, that's a good point, actually, James. I'm sure you didn't resent it at all. Thank you, James. So on that correction, are there any other corrections anybody else would wish to make, please? No? Okay, Stephen, are we all happy, therefore, to accept them as a true record? I'll take that as a yes. Thank you very much. Can I also ask, if you are raising your hand, to take your hand back down once you've answered the question? Otherwise, I'll come back to you. So thank you, James. That's brilliant. Okay, thank you, everybody. So on that, the basis of the 14th of January minutes have been approved as correct with that one amendment. If I can then move on to the actions and matters arising of the 14th of January, please. And I'm going to pass over to Stephen again. Thank you. Stephen.
Yeah, thank you, Chair. The first two items, flash glucose monitoring, bariatric surgery, not due still for some time, are in progress, and we've got updates scheduled into the forward planner going forward. Third item around Joint Committee Labour representation, that's complete. And in relation to the fourth item, cataract surgery, the task group has not met since the outbreak of the pandemic. Work has largely halted on that, and that'll be covered in a bit more detail in later items on the agenda.
Okay, thank you, Stephen. Any comments on those action notes or matters arising? No? Okay, we can move on then, please. Thank you very much for that, Stephen. If we can then move on to agenda item 8220, please, the Joint Committee Governance Report. Again, this is one of yours, Stephen, and I'm going to hand over to you for this one as well, please, to present. Thank you.
Okay, yeah, thank you, Chair. Yeah, this report summarises the key governance issues affecting the Joint Committee since it last met in public way back in January. Since then, the focus on dealing with COVID has meant that some business usual activities had to be done virtually, for example, the approval of the annual report. But for the record, that is attached at Appendix 1 for your information. Obviously, COVID has significantly disrupted both normal services and governance arrangements. And this, combined with the fact that the previous Joint Committee work plan had largely run its course, has meant there's been no actual requirement for the Joint Committee to take any formal commissioning decisions since the COVID lockdown. Going forward, and recognising the need to refresh the work plan, you'll recall that work to develop a new MOU, including the work plan in terms of reference of committee, was started back in January, and at the development session in March, the committee recommended that revised MOU and work plan be presented to the individual CCGs for consideration. And just to remind you, the main substantive changes to the MOU are the delegation of some new commissioning decisions to the Joint Committee, both service and non-service specific, and in Schedules 2 and 4 of the MOU Appendix 2, you'll see full details of those new commissioning decisions. And secondly, changes in the membership of the committee, which the chair has already set out, with North Yorkshire CCG becoming an associate member rather than a full member of the CCG of the Joint Committee. The MOU and work plan has been approved by all of the West Yorkshire CCGs, with the exception of Greater Huddersfield, where we're just waiting final approval from the membership, which is expected by the end of this week. And once that formal approval has been received, the MOU and the work plan will come into formal operation. Moving forward, the committee's work plan will need to be further adapted to reflect the changes in priorities that have happened as a result of COVID, which are covered in a later item on the agenda. And as part of that, we will both refresh the work programme and the risk framework, which has always been a regular feature of the report to the Joint Committee. And once we've got the new work plan, detailed work plan in place, we'll bring a revised risk framework to the committee. With the forthcoming departure of Richard Wilkinson, we've got a process underway to recruit a new CCG lay representative to the committee. And finally, the other thing to draw your attention is to the membership of the PPI Assurance Group, which, following CCG mergers, has now got a core membership of only 5. At its last meeting, the group discussed possible changes to its membership and role to reflect that, and it's proposed that we come back to a future meeting with some proposals about how the membership and role of that group might change going forward. So that's the update. And the recommendations for today are: the Joint Committee is asked to note the 1920 annual report, to note progress in agreeing the new MOU, and that once we've had formal approval from all CCGs, that will be presented to the accountable officers for signature, and to request that a detailed schedule bringing together key milestones and decision points for the committee is brought to the meeting in public in October.
Thank you, Stephen. I've got a hand up here. Stephen Hardy, would you like to come in, please?
Yeah, thanks, Chair. Just to reinforce what Stephen said, really, about the PPI Assurance Group. I mean, you mentioned that the number of CCGs has decreased in recent years because of mergers. We now only have 5 substantive members of the PPI Assurance Group, and we're getting to the point where, when its key role of assuring the Joint Committee that its public and patient engagement is timely, appropriate and proportionate across the patch, it is questionable. So we've identified the problem, and we're looking through Stephen's office at solutions for the JCC to consider, which may include opening invitations to other lay members on CCGs and/or associates.
Thank you, Stephen, for that. That's a fairly recent update, that. So I think we just basically need to make sure we are as transparent and get as many people involved as possible. So thanks for that, Stephen. Any other comments from anybody wishing to make on any of that? Okay, so we're basically noting the annual report. We've noted the progress in agreeing the new MOU. We hope to hear from Greater Huddersfield very shortly in the next week. Requests that a detailed schedule be based on revised work plan be presented to the meeting in public, and request that further work be done to explore the future membership of the PPI Assurance Group. I presume we're all happy to progress that. Okay, for me, just one other point, if I may, as chair. On the last point, the PPI assurance group, Stephen Gregg, it would be helpful with you and Stephen Cleesby if you could come back and give me some timeline as to what a solution might be for that, or what you think the future membership might be, please, at our next meeting in public. Is that okay?
Too many Stephens, but maybe not my role. I don't know.
Stephen Gregg with
Stephen Hardy, yes, yeah.
It's Stephen Hardy,
we'll,
not Stephen Cleesby.
Yeah.
Yes, thank you, Stephen Hardy.
Yeah.
You can join us if you want to, Stephen. Keeps the Stephens together. That would be really nice.
Okay, call it in the Stephens team, yeah.
The Stephen team. No, not at all. Sorry, Stephen. So are we all happy with that then? Joe, do you want to come in there, please?
Yeah, I just feel that, thank you, Stephen. It's a really important paper, and I agree with everything that's contained with it. They're just a bit on the sort of PPI assurance, and I know that we need a sort of vibrant assurance committee, and we need to make sure that it's representative of all our places. But there's an awful lot of PPI that goes on at place and embedded within our programmes. So I think what I'm saying is that in understanding what our future arrangements might be, we really do need to capture, of the programmes that I'm SRO for, there is lay representation in there. So it's how do we galvanise that support to make sure that it's connected to that piece that forms the basis of which joint committee takes a view from it, really, rather than doing something different. And I know because I've had that conversation with you, but I just thought for the purposes of this meeting, we do need to state out the obvious, really.
Yeah, thanks for that, Joe. And I think it's important to remember that we do include people at that level. So very important point. Okay, on that basis then, are we happy with the rest of that update from Stephen on the Joint Committee governance arrangements? I'll take that as a yes. Thank you, everybody. If I can then move on, please, to the next agenda item, which is 8320, our response on COVID-19 implications for the Joint Committee, please. That's going to be presented by Ian. So over to you, Ian Holmes. Thank you.
Thank you, Chair. Morning, everyone. It's nice to be back in this forum after a little while. So as you mentioned at the start, Marie, the work that we've done over the last 4 months has been significantly different. We're working in a different way. We've picked up quite a lot of new stuff. And the purpose of this item is twofold, really. The first is to give the Joint Committee an overall update on the work we've been doing across the ICS in response to the COVID pandemic. And secondly, is to think about what this means in terms of the role and the work plan of the Joint Committee going forward. So I'll start by providing that overall update, and then secondly, I'll talk a little bit about the specific areas of work that are delegated to this committee and what this means for the committee. So I guess the first point to make in terms of the overall response is that the ICS doesn't have a formal role within the command and control chain in response to the pandemic. There's an NHS route through the Incident Control Centre and a wider local authority partnership route through the Local Resilience Forum, which handle that sort of formal response. But I think what's been clear is that we'll only respond effectively as a system, and the collaboration, the partnerships and the way of working that we've built over the last 4 years is going to be really important and has been really important in ensuring that we respond effectively. The three principles that we work on as an ICS continue to be important. So are there any scale issues where you need critical mass that we can support on? Are there any wicked issues that we're all battling with that might be helpful to work on together? And is there any good practice that we might want to share and adopt across the system? And I think one of the things that's been a feature of the last 4 months is the degree of innovation that's happened that I think we can all learn from and share. So within that, there was a significant refocusing of our work in response to sort of almost the immediate phase of the pandemic, what we call phase one, which was March and April time, when we were dealing with a significant increase in the rates of infection, and we were looking at the impact of that on the wider system. And we had 4 overarching themes in terms of our response on phase one. The first was how we work to improve critical care capacity that we thought we might need to deal with that surge in response. That included increasing capacity in acute providers, working with independent sector providers differently, establishing a Yorkshire and Humber Nightingale facility in Harrogate, and that was really important at a point where we weren't quite sure how steep and aggressive that sort of curve was going to be in terms of the pandemic. The second point, and related to that, was supporting safe and effective discharge from acute trusts, so that there was, as much capacity there as possible, should we need it. The third was the work that we're doing to support shielded people, so people who were shielded because of underlying health conditions and other populations that we knew would be disproportionately affected by the impact of social distancing. And fourthly, it was around maintaining essential business as usual services. We know that health conditions for things that aren't COVID related haven't gone away over the past 4 months, and ensuring that those services are provided is really important. So that was kind of the real focus during March and April, I would say. As part of that, we established 2 new programmes across the ICS to support the local response around testing, which was led by Martin Barclay from Mid Yorkshire Trust, and supply of personal protective equipment, which was led by Mel Pickup from Bradford Teaching Hospitals. And I think what we saw during that period, although there was a significant growth in the rate of infections in hospital, demand resulting from that, the services here weren't overwhelmed, and we were able to respond, as effectively as we could have done under the circumstances. We've then moved into kind of what we call phase 2 and 3, where the priorities across the ICS have expanded out somewhat. So I've listed the 6 sort of priorities relating to those phase 2 and 3. So the first one is continuing to provide care for people with COVID, both in terms of the critical care capacity, but also in terms of the sort of the wider services, including recovery and rehabilitation. The second one is around, as I've said, maintaining essential non-COVID services and providing arrangements for those to be in place and effective. Thirdly, and it's similar to the phase 1, which is how we continue to support the population groups that are shielding, given the period of shielding there. The fourth one is around the work that we're doing to support health and care staff during COVID. This is in terms of the short-term support around making sure that we've got access to PPE and testing, but also some of the longer-term consequences that we're expecting for staff in terms of burnout, stress, those sort of things, and some of the work that the Clinical Forum has been leading has been around, how we get the right sort of well-being offer for those staff, including Black, Asian, minority ethnic staff, where we know there are specific issues. The fifth one's around the work that we're doing to really understand the impact of the virus. So there's a lot that we're starting to understand about the virus in terms of the short-term impact on males, on older people, on people from a Black, Asian, minority ethnic background. There's a lot of things that we still don't understand about it, including some of those wider impacts, some of the wider inequalities that will result from COVID, and some of the consequences of things like economic downturn and recession and those sort of things that will inevitably result. And so there's a lot of work happening there, led by our public health colleagues in our Improving Population Health programme, to understand that. And then the final one is thinking about how we move towards more of a kind of a business as usual model. It's not going to be business as usual, what we're calling stabilisation and reset, which is how we provide services well, in a way that builds on all the learning that we've had over the last 4 months and recognises that COVID is still going to be with us for the foreseeable period. So that's the kind of the shape of the sort of the programmes of work for the rest of this financial year, really, and that's the work that we're doing. As part of that, we've asked all of the West Yorkshire and Harrogate programmes of work to make sure that their priorities support our response, and so the programmes have been through a process where they've stopped some work where it doesn't make sense to do so in the current environment. There's the work that we need to continue because it continues to be important as business as usual, and the work that they want to step up as part of the supporting the efforts around COVID, and what we've what we've done today is share with you a plan on a page. So there's 6 plans on pages which are annexed to that document, which are a kind of a concise summary of all of the work programmes that have got delegated, that the Joint Committee's got delegated authority from CCGs for, to give you a sense of where they are and what their priorities are over the rest of this financial year. And I think what you can see in there, there's a good blend of ensuring kind of business as usual services. There's a real emphasis on the work that those programmes are doing to respond to the pandemic, but we're also clear that it's quite a fast-moving, dynamic environment, and programmes are working in a sort of a more fleet of foot way than they have done previously. What we'd have liked to be able to have done in this meeting in an ideal world was say, here's the plans on a page, and this is then what it means in terms of the future work programme for this joint committee. Because of the pace that we've been moving at and the fact that this is relatively new material that we're sharing today, we don't have that specific kind of work plan and those forward plans. But I guess what I'm asking from you today is just your sense on those plans on the page and where we are with those, and to acknowledge the fact that we'll come back to a meeting probably sort of later in the autumn where we then share the more detailed forward work plan. The one plan on the page is slightly different from that is the planned care one, where there's a more fundamental review of the way of working of that programme, including trying to bring it together more closely with the acute trust work around planned care transformation. So that's the next item on the agenda, where we'll have a bit more of a deeper conversation around the sort of the new planned care priorities. The final thing I'll say is that all of this is connected to the wider piece of work that we're doing around the future of commissioning that's being led by Esther Ashman. And again, we'll have a future conversation around what those arrangements might look like, and we'll engage with the Joint Committee on those issues. So that's all I wanted to say. Thank you, Chair. Hopefully committee members will receive the update, and grateful for any feedback around those plans on a page and the next steps. Thank you.
Okay, thanks, Ian. Okay, I'll open that up to everybody. Joe, you still got your hand up. Do you want to come back on that, or is that the last one?
It's the last one. I'll lower my hand. Sorry.
Okay, no problem. Okay, so obviously that's quite a bit of work going on there, Ian. It's obviously changing the shape of the future, and our priorities. COVID's had a massive impact on that, changing what we're doing. The detail which will come out, as Ian said, later on in the summer in terms of those key priorities. Is there anything anybody would wish to raise specifically with Ian today? Gosh, yes, here we are. James, yes, please, James.
So thanks, Chair. And Ian, I think kind of summarise what's been going on. And as you said, we've been very agile. And the pace has been quick. And I suspect the fact that there's not many comments is because I think everyone has been involved, or a lot of people on this call have been involved with a lot of what's been happening there. I suppose my question is kind of how do we ensure as a committee between now and the autumn that we are involved in that? And I suppose as a committee, I appreciate individuals here will be involved, but and I suppose it's making sure how we feed into those changes that happen between now and then, on not just an individual basis, because I think that will happen, but as a committee. I just wondered, is there a discussion on that, because we've been agile in lots of other committees and forums to make sure that whether it's steering groups, whether other groups, so that people felt involved as it's changing every week, month, whatever it is. So I just wondered, any thoughts?
Thanks, James. Joe, do you want to come in on that, please? Joe Webster.
Yeah, I think that's a really important point, James, and part of the development of the journey that we're on around commissioning futures, and much of the plans on a page consolidate some of the opportunity that COVID's brought to do things differently, or accelerate some of the aspirations we all had, because I've been overwhelmed by how much progress we've made on some of the collaboration approach that we've all been striving towards. Is the part of the journey, and we're planning to do a development session in August that almost consolidates some of that work and starts to inform what the work plan might be, and then how the joint committee needs to consider its role in what are the kind of assurances it needs to take if these are the kind of decisions that we might have to make in the future. So I think that's part of our journey. So we're planning a development session in August, and then obviously there will be a way in which we engage the whole of the partnership in that, because it's not just what the Joint Committee do, because we are a commissioning partnership. I think we've talked about that many times, and we do need to get a firm proposition on that, if that gives you any comfort that there's a plan.
Thank you, Jo. Okay, any other comments from anybody else? Okay, so the recommendation from this paper then is note the approach set out in the response to the pandemic, and note the programme priorities for the next phase of the response. And the other one is to note the next steps to develop a revised plan for the Joint Committee based on new priorities, I think, which we've all agreed we're expecting in sort of mid to late summer. Okay, happy with that? Okay, thank you everybody. Happy with that particular paper. Thank you, Ian, for that. Okay, if I move on then please to agenda item 8420, improving planned care, the programme refresh, please. I know I think Katherine's presenting this paper, so Katherine, over to you. Katherine Thompson, thank you.
Thank you, Marie. I'll just give a very brief overview. As Ian indicated in the previous item, the pandemic has fundamentally changed the planned care programme and the work that we need to do, but it has also accelerated the existing plans that we had to bring together the what was previously called the Elective Care and Standardisation of Commissioning Policies programme with the WIAT elective surgery programme. And so in thinking about how we restarted our programme work, we decided we shouldn't restart in any form other than as a single programme. So rather than doing that gradual integration, we've just gone the whole hog and we are now one programme. And I think it's working quite well so far. With that comes a refreshed leadership. So I'm really grateful to Jo Webster for agreeing to be the new SRO from the commissioning side, and we also have Steve Russell from Harrogate District, who is our provider CEO lead, and alongside James Thomas as our clinical lead, we've welcomed Sal Yuka, who is the WIAT clinical lead, and I think that really strengthens our links with the clinical forum and gives a kind of wider clinical perspective on the programme. So I think that's a really positive development. We have followed a bit, I think, the model of the Cancer Alliance, and so we've called our programme board, our new programme board, an alliance board, and we met for the first time a couple of weeks ago. We'll have another one next week. In the first meeting was really positive, really good discussion, and some really clear agreement on the ways in which the programme can support the restarting of planned care services across the partnership. We identified that it was very important to do only the things that are best done once across West Yorkshire and Harrogate through our programme, and the things that are best done at place are best done at place. But there is still a role for us in supporting that sharing of learning between places. So the priorities that we established were that we would do some work to support the restart of elective surgery. You'll see attached to the paper a bid which we have put into NHS England for some funding to create a virtual hub. This is a national programme, and I think there is a desire nationally to have that sort of ICS-based approach to supporting elective surgery and elective care across England. So we've submitted that bid. We're waiting for confirmation of funding, but our approach remains the same within that hub as the approach of the partnership, that we have primacy of place, and it will be about places working within themselves to best deal with their elective care needs, but where demand is greater than available capacity, potentially either because of the health needs of the local population or because of subsequent surges in COVID, significantly reducing the ability of a place to manage its ongoing planned care needs, that we would support an approach to kind of mutual aid between places to make sure that our population health outcomes and our equity and access to care is maintained throughout the coming months, and certainly the whole of the rest of this financial year and into next year, while we go through this pandemic period. The other part of that is about optimising the use of our diagnostic facilities. We'll be working very closely with the Cancer Alliance on this. They already had a piece of work on process efficiency, I suppose, within the WIAT provider organisations, and we are going to coordinate in with that piece of work and sort of wrap round the edges of it, some work to ensure that the available capacity for diagnostics that is in the independent sector, some of that which is as part of the national independent sector contract and some of that which is locally commissioned, is optimally used, and where there is any unused capacity within a place, that is made available to other places to make sure we don't have any unused capacity, again just so that our people are able to access the care as quickly as possible. Then the second priority is thinking differently about pathways, and I'm going to use the word referrals because we don't have a different word yet, but we want to get away from that concept of referral and handing over care from one sector to another. We really want to take a whole life course approach, really focus on prevention, shared decision making and personalisation, and you will recognise those principles and that ethos from how we worked as a programme previously. I just think we need to really, really invest in those things. But we want to see an approach to a sort of shared responsibility for care, and then perhaps building on approaches such as advice and guidance, so that only people who need to progress into secondary care services do, and that most of what can be done in primary and community services is done. This approach to kind of shared, it's almost like shared decision making with primary and secondary care about making that referral. They are things that places are doing, they have started doing already. It's not about coming up with a single approach to that, it's about supporting some principles and helping places share and learn from each other, so people aren't reinventing the wheel. We just want to recognise good practice that's happening and share and spread that, rather than hold anybody back from making really good progress at place with how they support referrals into more specialist care and more specialist services. So clearly we had quite a big programme of work prior to COVID. Some of that we are going to need to continue to support because it's important to the ongoing provision of planned care services, notably the area prescribing committee, which will be meeting in August for the first time, and also the piece of work to develop first contact practitioners. As usual, we will support the planning guidance deliverables as they are confirmed by NHS England and improvement. But the rest of the work we will pick up where it supports the restarting of planned care in the first instance, such as in the time critical eye services particularly. And that's not that the other work that we have still paused is unimportant, it's just that it's not going to deliver the greatest benefits at the moment to getting planned care services up and running. And understandably, both clinicians' time and managers' time is focused on the getting things restarted, and we don't want to be diverting focus away from that into things which were important before but less important now. I think I could stop there and take questions.
Thank you, Catherine. So thank you for that. Any comments from anybody? Steve Ollerton, please.
Hi, Catherine. Thanks. This is a very interesting piece of work and a very tricky one. I just know I'm having a lot of issues at the moment on my patch with primary care or general practice, sort of not being exactly willing to take on this new work. I mean, all this shared decision making, advice and guidance, or you know, don't get me wrong, I'm all for it. But there is this thing that this is handing work back from secondary care to primary care, and then they always start talking about, well, I'm hoping funding's going to follow and things like that. And please don't think this is my view, it's not. But I have LMC colleagues and things, and you know, and we're pre-COVID. You know, we always had the BMA letters that as soon as a secondary care clinician asked a GP to do an X-ray, they were up in arms saying, "This is not our work. You're handing work back to us." And all that you've just said is handing an awful lot of work back to general practice, and we do need to look at how that's managed, because the knee-jerk reaction from general practice is we, you know, don't necessarily want this work, I'm afraid.
Yeah, thanks for that, Steve. Do you want to come back on that, Catherine, or Joe, maybe? Joe?
You, aren't I? And Tim wants to say something as well. I don't know whether you clocked that, Marie, in the chat box. He hasn't got a hand. I think he's having Microsoft Team issues today. Okay,
thank you. I'll bring Tim in. Sorry. Yeah, thank you.
So no, I think you raise a really important point, Steve, and even though I'm having some really positive conversations in Wakefield about a new way of working between shared decision making between primary care and secondary care, it's only with a handful of GPs at the moment, and I've got a spectrum of this is going to be far too hard to do for us to we can't. We can't see any other way of managing this, and you know, we're all up for it if we use digital, etc., etc. I think that the impact on primary care and secondary care to some degree, because it does require them to change. This is about a whole system transformation. It'll change for the way in which we manage, as you've described it, our referrals into secondary care. And I think with the support of the clinical forum, and the way in which we want to approach this is that we really do need to be transparent in the impact it has on all the sectors, and try and find a way through that. Because what I do know at the moment is if we continue to do our behaviour drives our demand to some degree. I understand the socioeconomics drive demand as well, but our behaviour contributes to that. And we know that if we continue to just refer into secondary care, they haven't got the capacity, and that's all it will do is exaggerate the long waits that some of our populations are actually facing at the moment prior to COVID, let alone the impact of COVID, and then the wider implications that would have on outcomes and inequalities. And I know, Steve, that you are speaking on probably the majority of GPs feeling quite anxious about how do they manage all this at the moment. And there's lots of them on this call that are all smiling and looking now down at the computer thinking, yes. But I think we've just got to get into that space. You know, we've got to work through this, and we've just got to get some willing partners to work it through as best we can, really.
Yeah, thank you for that, Joe. Can I just bring in Tim, and I'll come back to Catherine? Is that okay? Tim, please.
Yeah, a couple of comments and then just a bit of sort of curiosity, really. I think the first one is just around the difference between the language of papers and the language of conversation. And I know the paper that's come around the planned care response and the virtual hub has probably created a few antibodies, which are very different from the 3 conversations I've now had in the last 24 hours about the messaging. So I think there's something really important about emphasising the support to place and the primacy of place, which comes over in the language but less so in the documents. And I think particularly the virtual hub piece, to be clearer on the scope and breadth of what that might do would be really helpful. I mean, things like endoscopy and CT we all get. if we're thinking of 500 lines of an outpatient list at each trust and trying to manage those in some central way. And I've had the conversation, but the paper could be read like that and has been read like that. So I think it's quite important that we just get that nuance right as we go forward. I suppose the curiosity bit was on the priorities, particularly around prevention and whole lifestyle. What's the work being done in terms of conversations with other programme boards and places? This more than duplicate, it could be triplicate work, because those things are there and part of everything. And I'm just nervous whenever I see them being brought in as though planned care is about prevention. I struggle with that a little bit. So I'm just curious about what the conversations are that are happening.
Okay, thanks for that, Tim. I'm going to bring Katherine in then, James, please. So, Katherine?
My first comment was just to echo what Joe had said in response to Steve's comment about primary care. And I support everything Joe said wholeheartedly. And I think what we really need to do is think about making sure that our population of people who need care in West Yorkshire and Harrogate get the best care and the safest care that we provide, and we need to put them at the centre of our plans rather than the needs of each organisation, and make the system transformation work for everybody. But it's going to take change. But the most important thing is to put the health of our population at the centre of all of our plans, because that is the most important thing. So in response to Tim, I totally hear what you're saying. I think some of the writing of the virtual hub paper is about it meeting the needs of the funders, and then we'll apply it in a way that meets the needs of our places and our system. And what we are able to do will be influenced by how much money we are successful in bidding for. So we will define the scope based on what will be the most useful to places and what we will have the resource to do based on how much funding we get. I did kind of, in the paper, the links to the programmes thing, I did try and indicate links to the other programmes. I don't plan to start a whole piece of work on shared decision making or personalisation or anything else that is the fundamental work of another programme. It is about working collaboratively and in a matrix way across programmes. And I do have a meeting with Katherine Giles actually this week about the links between this programme and the transformation and how that impacts on primary care. We've already spoken with the Cancer Alliance. In fact, they're very fundamentally involved and integrated into the work, and already having conversations with particularly the personalisation programme. So totally agree with you. Don't want to do anything more than once.
Yeah, thank you, Katherine. James, please, your comments, please. James, Thomas.
Thanks, Joe. So I actually just follows on a little bit from what Katherine said, because I wanted to, I mean, Steve highlights some significant challenges, but we know there are lots of challenges out there. I think in terms of this morning at the clinical forum, we had some great conversations around personalised care, and it goes into what Katherine was just mentioning there, because I think there are some links here with the programmes, whether it's primary care and communities programme, whether it's the personalised care. Personalised care has to be embedded in all our programmes, and especially in this programme here, because that's where we're going to get that's the focus. That's the focus of our attention. We had a fantastic presentation this morning about the benefits and also the challenges we have with personalised care, but that has to be fundamental and part of this programme there. I think it's about outcome based as well, and what we're looking at in terms of it's not about just waiting lists. It needs to be about outcome based. The referral, we talk about the journey, the patient's journey. It has to be about that patient's journey and the focus from both primary and secondary care. And I think from the clinical forum this morning, I think there was a real, the principles were discussed this morning about reset and restoration and clinical and how we clinical prioritise as we go forward there. It's embedding population health into this and population health management there. So there was support this morning in the clinical forum for the principles and having a framework there. The practical application of this is the challenging part of this, whether that's with personalised care, whether that's with primary care, whether it's with secondary care. I think there's some good shared learning, and that's one of the things as a partnership we are good at and we need to be. There's some good shared learning we can do that we were hearing this morning that was happening in Calderdale. We know what's happening in Bradford as well, and Leeds. All our places there have got some learning that they're doing, and it's how we bring that forward there and together to help this program here. So it's not down to just this program. We all know that. It's absolutely, Tim. It's not about duplicating things, both in program, place, or communities. But we've got to be mindful of this, and I know we all are, about the challenges. And it's going with the willing to a certain extent as well, and trying those things out.
Okay, thank you for that, James. If I could bring Ian, please, Ian Holmes.
Thanks, Maria. Firstly, I really support the direction of travel in the paper. I think a lot of the conversations we've had over the last couple of years have been about how difficult it's been to implement the proposals and priorities from this programme over the last 2 years, and actually building a system-wide programme with why I think will really help to get stuff done, and hopefully some of that conversation will go away now, which would be great. Secondly, I agree with the points made around subsidiarity in a place-led West Yorkshire and Harrogate supported approach. I think there's increasingly going to be a push from the centre for a system-wide response to this stuff, and the way I see this is West Yorkshire getting ahead of that and developing an approach that makes sense for us. So absolutely no intention to move to West Yorkshire, to a single West Yorkshire PTL, but some mutual working and mutual support, particularly around the diagnostics, IS capacity, I think is exactly in the right place. So I really support that.
Thanks, Ian. Okay, Stephen Cleesby, please. Stephen.
Thanks, Chair. Yeah. So I think it's almost impossible to overstate the importance of this piece of work. This certainly, in my mind, is the top priority for our CCGs, for our systems at this moment in time, and for the next few months, probably for the next 6 to 12 months at least. We're not just talking about a slight change in the way that we do things. We're talking about fundamental transformation that's been thrust upon us. So it's not like we need to, we'd like to have a go at this. It's an area that we've identified as that's important. This is something that's fundamental to the success of our systems in the coming months. We're looking at sort of, in most clinical specialty areas at a hospital level, 30 or 40% of capacity compared to pre-COVID. So with that change being thrust upon us, I think that one of the main features is how we can build strong relationships between the different parts of the system, particularly between these artificial divides around primary, community and secondary care, where they've been fraught with challenges in recent months, recent years, and strong relationships working together. That's surely what commissioners are all about. It's not just about contracts and tendering and holding people to account on data and dashboards and things, as important as all that is. We need to foster strong relationships. So that comes to really, really strong managerial, executive, and I guess clinical leadership. We need to be out there. This is the game. This is the thing in town. This is a big show, and we need to then put resource into it. And I'm not just thinking about throwing money at it, because that's going to be a challenge in the next 6 to 12 months as well. I'm sure we're going to get a financial rebound. So I don't think it's about money. It's about prioritization, and it's about human resources. It's about our managers and our people that we actually point towards this challenge and arise to that. And of course, there's this hub that's being mentioned, which is, may or may not be the thing that the deal breaker. But as Katherine was saying, what we're going to be able to do depends on how much resource we get. I think this has got to be the resource that we have in our system that's going to be brought to bear on this challenge, rather than just some transformational money that's going to. But the things that we're looking at in that blue diagram down at the bottom step 1, step 2 and step 3. This is a massive change from what primary care and GPs particularly are accustomed to when they see patients. It's been very simple to make a quick referral, and then to some extent you sort of drop the can there, you pass the responsibility on, and we're talking about shared responsibility of all partners in the system in terms of this planned care approach. It's so fundamentally transformational. I can't overstate how important it is. We've got to get it right, and we've got to get it right quickly.
Thank you, Stephen Cleasby. Steve Ollerton, please, and then Joe Webster. So Steve Ollerton, please.
Thanks, Chair. I agree with Steve there, and I just wonder if this is so important, which I think you're right, putting a bid into NHS England for 1.2 million, and what if they say no? Is this important enough to be looking for the money elsewhere? Sorry, somebody have to ask you.
That's all right. Thanks, Steve. Okay, bring in Joe, please, Joe Webster.
No, I just wanted to support what Stephen had said. I think that was actually beautifully articulated, may I say, on what the challenge is. This isn't complicated, it's complex and complicated, and it is absolutely fundamentally going to change the way in which we all work. Even the way in which we commission and everything. And it isn't about PTLs and waiting lists, it's about outcomes for people. And making sure that if we have capacity across West Yorkshire to deal with some of those fundamental inequalities that people are facing through access to care and things like that, that we use them wisely, and we look at it at a population level that's built up from place, but also that can be shared across. I shared an example this morning with my colleagues around some of our endoscopy services, and we know we've got a lot of people waiting for endoscopy service tests at the moment. And we know that we have capacity to do that, but if we stick to our traditional arrangements, we may not be able to get through all that because we can't staff the independent sector in the way that we used to, etc. And, I just think there's some really obvious ones, and then there's some real ones that just need to stay local, like the care of the elderly and all those things that are really embedded into some of that sort of local pathway stuff. So I really thank you for saying that, Steve, because it's really, really important, Notwithstanding the fact that bringing people along the journey is the hardest part that I think our commissioner function's going to have to do in the future, and creating those spaces for people to work differently together is a real challenge for us all. So the organisational development requirements is fundamental to this.
Thank you, Joe. Thank you for your comments on that. Okay, any other comments people wish to note on this particular paper presentation from Katherine today? No. Okay, so we're being asked then, if I may, to note the integration of the two programmes to form Improving Planned Care programme, to support the proposals to address access to diagnostic testing and elective surgery, and support the proposal to address referral and support proactive approaches to managing planned care. I think we're asking to note and support. Yes, happy to do that. Yep, okay, thank you very much, everybody. Is that somebody trying to come in, or is that just a noise?
Yeah, Maria, I just would like, given that Stephen's comments, I think through the chat we're all agreeing with Stephen, and the fact that we all need to get behind this as leaders. I would really urge all of us to take this paper back into our teams, back into our clinical discussions locally, back into all those mechanisms, our partnership discussions, so that we can really get some energy behind the way in which we want to work, notwithstanding that the detail of it needs to be considered. But I think it's just about winning that hearts and minds over, and making sure that people really understand what we're trying to do. And I completely take your point about the paper that's been circulated, Tim, and some of the language that we've used in that. So we'll change that paper to reflect the conversations that you've had over the past 24 hours and get that in the right place.
Thank you for that, Joe. I think it's well summarised, that the action taken forward. Okay, so on that basis then, are we happy to move on? Yep. Okay, thank you very much, everybody. Well, that was our last paper of this morning's session and in public. So is there any other business from anybody else, please? Richard, would you like to come in, please? Richard Wilkinson.
Yes, Marie, thank you very much. Obviously, it's my last meeting today, so I thought I wanted to say something at the end of it. And I wanted to thank everyone for their comradeships over the time I've been here. I particularly want to thank you, Marie, because you were there at the start as I was at the start. And I think the committee's come a long, long way. So when you're in amongst the thick of it, as you clearly are, and when you've got challenges like COVID, I'd like you all to remember occasionally to stop and give yourself a pat on the back, because I've seen such dedication around the table over the couple of 2 or 3 years that I've been here. And I think we've achieved a lot. But of course, health is like education, it's like housing. You're never done, you're never there, you can never bottom it. But I've seen some fantastic spirit and I've seen some great progress, and I shall miss you all. And at some stage when you do meet in public, I might just turn up and heckle and bring a few guns.
Yeah, thank you for that, Richard. Well said, and I endorse what you said. I think the committee, as a group of professional people, have done a really great job and still continue to do so. So thank you, Richard, and thank you for your contribution as well. Okay, anything else from anybody else then? No, on that basis then, the next meeting in public will be Tuesday, the 6th of October 2020, 11 AM. I assume still in October will be in this format. If it's any differently, clearly we'll know. But on behalf of myself and everybody else, thank you very much indeed, and enjoy the rest of your day, and all the very best to people leaving and all the very best to people who have now joined us. Thank you very much indeed. Thank you.
Thanks, Marie. Thank you.
Chair. Thank you, Chair.
Thank you.